Neurosurgery chose me. I didn't choose neurosurgery. We need to educate neurosurgeons around the world with how to make lesions. And I didn't believe in intraoperative MRI, and now I'm a complete convert. Osler was a distant relative of my mother's. So, Osler...
Welcome to Stimulating Brains.
In this episode of Stimulating Brains, I'm joined by a true pioneer in the field of functional neurosurgery and a very dear colleague of mine, Dr. Rees Cosgrove. Currently serving as Director of Epilepsy and Functional Neurosurgery at Brigham and Women's Hospital and a professor at Harvard Medical School, Dr. Cosgrove has not only shaped the field over decades, but also witnessed and driven its most transformative evolutions. From his early surgical training at the M&I in Montreal under the shadow of legends like Wilder Penfield, to his years leading programs at Mass General Hospital, Brown University, and now the Brigham, Dr. Cosgrove shares a wealth of insight and experience with us. He has performed thousands of procedures across the spectrum, from ablative surgeries for psychiatric and movement disorders to modern-day deep brain stimulation and MR-guided focused ultrasound, where he has risen to a key global figure with over 600 sonications performed. Beyond the OR, Dr. Cosgrove's journey into neurosurgery is anything but typical. He said that he didn't choose neurosurgery, but in a way, neurosurgery chose him. We'll begin with a story involving his father, a dog with seizures, and an early glimpse of surgical destiny. From there, we talk about pivotal mentors, the legacy of psychosurgery, and the rise of high-precision imaging techniques. You'll hear fascinating anecdotes, including one about a patient he shared with Dr. Lori Leitinen in Stockholm. We also include guest questions by John Ralston, Clemens Neudorfer, Melissa Chua, and Mike Fox, who help us dive even deeper into topics like mentorship, ablative surgery, and the future of neuromodulation. Whether you're a neurosurgeon, neuroscientist, or just curious about how the field stimulates the brain, this conversation is packed with history, innovation, and personal insights. Let's dive in. Thank you so much, Rees, for taking your time out of your busy schedule to meet and talk about your life in neurosurgery and neuroscience. And before we dive into that journey, I always ask an icebreaker question about hobbies. Anything you do when not working?
What I love to do is travel and sort of take adventurous trips with my family.
Yeah.
Mostly I like to be outdoors because for me, nature restores me. And I did a 14-day tour, trek in the Himalayas with my middle daughter last November. Nearly killed me. It was so high. And then, I've taken my family rafting down the Grand Canyon.
Oh, you did? Wow.
But really for me, I like to be outdoors, in nature.
Yeah.
Hiking, skiing, biking, traveling, just seeing the world.
You just came back from skiing.
I just came back from skiing. I spent several ski out west.
Yeah. Only made it once to ski here in New England, and it was before my first son was born, the day before, actually.
Oh, dear.
You came early. So I'm, haven't had much of that in the last few years, but I'm sure it's exciting to do that here.
Well, the skiing the East is not the same as skiing the West. I've skied all through the Alps, in Switzerland and Austria, Italy. It's fantastic. Yeah. It's maybe even better than the West because of the culture, the different cultures.
Fantastic. So your journey into neurosurgery, I think, began very early in life and in quite an unusual way. You told me a fascinating story about that once when Ludwig Swinzer was visiting Boston. Can you tell that story again about the dog, the father?
Sure. So my father was a neurologist.
Yeah.
He studied multiple sclerosis, and he was hired by Penfield to be one of the handful of neurologists at the M&I. So I grew up in Montreal, and my father was a neurologist, and so we were always at the M&I they would have field days for the families and all the fellows and all those things. But the story is that we had a dog that we got from the pound. This wasn't a purebred or anything. Yeah. This was a mutt. And the dog was my dog, and I was about 8 or 9 years old, and this dog, after about 9 months, started having seizures. Yeah. So this was my first introduction to seizures in a dog. Yeah. So my dad gave me Dilantin. He says, these are seizures. Mm-hmm. He says, so we have to give him a pill, which is called Dilantin. And so my job was every morning to give him a Dilantin pill, wrapped in a little piece of hamburger so that they'd eat it. Yeah. And his seizures stopped. That's great. And I'm thinking, this is great. But then he started having more seizures, so then I had to double the dose. That was, But at one Sunday morning, I woke up and went down to get my dog, and the dog was in status epilepticus on the kitchen floor. Yeah. So I ran up to get my father, and he comes down and he says, well, this is status epilepticus. The dog's flipping and frothing at the mouth, and says, we have to put the dog down. And he was very much an experiential learner. So he said, gets my older brother and sister down, and they said, who wants to come? And we're going to put the dog down. And my older brother and sister said, no way. Mm-hmm. And I said, well, it was my dog. So I said, I should go. So I remember carrying the dog out and and having it on my lap, and we drive to the M&I where he worked. And on the 7th floors of the M&I, there were animal labs. Okay. All incorporated in the M&I. Yeah. So we went up on a Sunday morning to the animal lab, and we euthanized the dog with just a KCL in the heart, just a transthoracic stick with a big needle, and dog dies. And then my father says, well, if you want, this could be either brain tumor or distemper. And distemper is a slow virus that's seen in dogs. And said if it's a brain tumor, you can get another dog. If it's distemper, you can't for 9 months or so because it's a slow virus. Yeah. So he said the only way of figuring that out is we have to take the brain. So there I was at 9 years old helping my father take the brain of my dog. And we somehow got, we had rudimentary tools, and he was a neurologist, so he wasn't very good at it. And there was nobody there to help us, but we eventually took the brain, and then we put it in formaldehyde, and then 2 weeks later we came back and we sliced the brain. Wow. So my first case wasn't a good one, but that was sort of my first exposure. I'm not saying it was a fond memory. Of course. Yeah. But was that the one that kind of put you in that track? Not really. No. I mean, that was, it could have turned you exactly the other way, right? Yeah. No, but so I don't think I have a feeling, neurosurgery chose me. I didn't choose neurosurgery, not like some kids we see today. Yeah. People who say, I'm going to be, something motivates them and away they go, right? Yeah. Mine was just sort of because of my situation. When I was 15, where I couldn't really get a job, I didn't want to just be a camp counselor or a lifeguard. And I was sort of interested in medicine and the hospital, so he got me a job in Dr. Bertrand's lab. Oh, wow. Who was Gilles Bertrand, who was a neurosurgeon and my job was to take all of the ventriculograms and measure them and do the analysis. And because for his thalamotomies. So then I could scoot down to round. At 15, I was just like, I was in the hospital. Yeah. I also, when I was 18 and was employable, another summer I worked in a gas liquid chromatography lab doing anticonvulsant level testing and, doing more chemistry and that kind of stuff. And then I worked as an orderly.
What is that?
An orderly is like a nursing assistant, but you're the muscle.
Okay.
So that was a real pain job, and that was a good job, but in the M&I.
Yeah.
So, I was an orderly. You washed patients, you cleaned them up, you changed the beds, you held them during lumbar punctures.
Yeah.
And when I was doing that, I remember one time when I was holding this patient ready for his lumbar puncture, and the neurosurgery resident walks in and, and he sits down, sticks the needle in, the fluid comes out, and I'm still holding the patient, but I'm watching him, what he's doing. Yeah. And I'm thinking, ooh, I think I want to be that guy. Yeah. I don't want to be this guy holding the patient. Yeah. I want to be that guy who's in charge. Yeah. And so, that was sort of like it was my world. Yeah, sure. And I don't think I really chose it. It was just happenstance, but
you were born into it in a way.
Sort of born into it. And you're either drawn towards an experience like that, or you go in the other direction, right? Yeah. But it seemed to always interest me. Yeah. And even though I would go into rounds sometimes and really not understand exactly what they were talking, it was just fascinating to me. And so it seemed real. It seemed important. Yeah. And, if you think about the Freudian basis of this, it's one way of one-upping your father, right?
Say that again.
It's of being better than your father, right? We're competitive males, right? Yeah. So he was a very intelligent. He was the guy who described MS, multiple sclerosis, that it was an inflammatory condition. He described T cells, T cell rosettes in the spinal fluid of people, and oligoclonal banding in his lab. Wow! So he was a very smart guy, but he was a neurologist, and the only way to be better than a neurologist is to be a neurosurgeon.
Of course, you did tell me a joke about neurologists before. But
we won't do that. We might offend somebody.
So, and did you meet Penfield as a kid?
Yeah. So I met Penfield when I was a boy. Okay. He was I only met him once. And I remember we were standing in the vestibule of the M&I. Yeah. It's a beautiful, beautiful vestibule, very historic. Mm-hmm. And I remember I was a little kid, but Penfield was a big man. He was like 6'2", 6'3". Yeah. And he had big hands. And I remember him just leaning down to me and just focusing on me. Wow. And I remember shaking his hand. And I just remember looking up at this man.
Look at that. Wow. He was a football coach.
He was a football coach. He was a Rhodes Scholar. He was a football player, but then he became a coach at Princeton when he was trying. Yeah. So it was, I just remember these big hands.
I'm sure.
I thought, whoa.
Yeah. But, wow. Fantastic. And
I also saw Rasmussen's last craniotomy for epilepsy.
Oh, you did?
My dad, when I was, just before he retired, he brought me in to watch. Wow. Ted Rasmussen do his last epilepsy craniotomy.
Oh my God.
And you could go into this theater number 1 in the M&I.
Just been there.
All glassed in. Yes. Did they show that to you?
Abbas Sadiko just showed me that, and it still exists, and it's beautiful.
It's beautiful, and it has this glass that leans out, heavy glass. Yeah. So you can walk in street clothes, and you're hermetically sealed from the operating room. Yeah. But you can lean on the glass, which is at 45 degrees out, and you can look right down where they're operating.
It's fantastic.
It was great.
Yeah. Wow. So, okay. Oh my God. And so when visiting the M&I just weeks ago, there was even a hallway named after Penfield's wife, I think, still. And Dr. Abbas Sadiko, surgeon there, told me that was because family was kind of part of this at the time, right? Where, it resonates with you being there as a boy in a way too, right?
Yeah.
Was it?
So family, it was very interesting. In the early days, the M&I was like a family. People were there. They stayed forever. Even to this day, I remember going back sometimes years afterwards, and you go back onto a ward, and some of the same nurses were still there. They were so loyal to the vision of Penfield and the M&I. Yeah. And so it was very much like a family from at all levels.
Fantastic. Yeah. Such a historical place. Yeah. And so I mean,
did you love the vestibule?
I did.
With the paintings and the murals?
No, I didn't. Sorry, I didn't see the vestibule. No,
well, that's the entrance to the M&I.
Oh,
you
yes,
would have,
of course.
Nature
No,
revealing itself before science. And,
I do, yeah.
And the...
Absolutely, I love it. Yeah, with the names up. I do, of course, yeah.
Yeah, beautiful.
Really beautiful, yeah. Okay, so, I mean, you mentioned a few mentors already, or like turning points, but if you had to summarize, maybe looking more broadly at your career, who were the key figures, father figures, mentors in your neurosurgical career, or turning points like the ones you just described?
Yeah. I mean, obviously my father had influence, right? Yeah. And when I was a resident there, he was still an attending, so we'd have some interaction, but he wasn't my neurosurgical. I mean, neurologists don't really want, he was of the school where you had to protect your patient from the neurosurgeons, well, he wasn't like that, but most were. My Gilles Bertrand, who just a fantastic man, still alive at 100.
Wow.
I think he's 101 now.
Oh my God. Yeah.
But he was he was a master surgeon, and very thoughtful, very elegant in his technique, could do amazing complex skull-based surgeries. And, but he taught me thalamotomy.
Okay.
So he would be number one. He would probably be number one. André Olivier, who was a master epilepsy surgeon, taught me most of my epilepsy stuff. And then Jean-Guy Villemure, who was one of the attendings who really taught me to be a surgeon.
Okay.
They all taught me, but these were the surgeons that,
It was all at the M&I.
All at the M&I.
And then later, any key people in the career?
No, I think the people that form you are those people, and their standards, their excellence is what creates your value system and your standards. So they were the people. I mean, we were influenced by all sorts of people thereafter.
Did you ever interact or overlap with Tasker at all?
Well, no, Tasker was in Toronto. So I mean, yes, we did, because subsequently at meetings. And there was the sort of in Canada, there was the Montreal School of Neurosurgery, and there's the Toronto School of Neurosurgery. And, no, I guess the other person might have been Leitnen, and, who I spent some time with, in the early days. But
sounds good. We get to that story.
That story too. Yeah, there are stories.
So maybe this is a random question that didn't fit in elsewhere, but you, like researching you were also named an honorary Litchfield lecturer at Oxford University in 2008.
Yeah.
How did that come? Why Oxford? Like, have you spent time in Oxford?
No, when I was a medical student, I spent some time in Cambridge, because my father did his second master's degree in Cambridge. That's where he did his MS work.
Yeah.
At the old Addenbrooke's Hospital. But when I was a medical student, I had heard all these stories. My parents were married in England, and they lived in there after the war. So we had all these stories of England and, these romantic times and the hard times, because it was post-war. So they were poor and they didn't have many things, but it was so romantic. And so I spent an elective as a medical student in neurosurgery over there, and in transplant surgery.
But in Cambridge.
In Cambridge, Cambridge, England. Then as a resident, instead of doing pure research for a year, I had such a great time over there. I became a registrar over in Cambridge, England. Okay. So I have this, I think I'm an Anglophile.
Yeah. Okay.
Because, it's just, I love the English and their way of thinking and this was, I was great friends with Tipu Aziz.
Oh yeah. Yeah.
And Tipu and I were friends because of just the work we did.
Yes.
And, so he invited me to be the Litchfield lecturer, which is an honorary thing.
Yeah.
You go for a week and you lecture and visit and, but that was Tipu who arranged that for me.
Just talked to one of his kind of professional grandchildren, John Arifai, who is a surgeon there now with Alex Green, and he also had a question for you, so which we come to later. So yeah, interesting. Okay, and then maybe one guest question from Melissa Chua was, why did you then move to the US from Canada?
Well, I moved here. I made the mistake of marrying an American.
Okay.
No, so it's interesting. So, in Canada, the healthcare system is very different. So I finished, I was going to be a cerebrovascular surgeon because that was the most complicated, the hardest surgery. You needed the best skills.
Yeah.
And I was going to be Roberto Hiros's first fellow at the MGH.
Okay.
Roberto Hiros was the big guy in cerebrovascular surgery. So I was going to do a 2-year fellowship with him. One research, one clinical, because I was going to be a cerebrovascular surgeon because that was the hardest thing to do.
Okay.
About 6 months before I was about to sign on, I get a letter. He says, the fellowship is no longer available.
Ooh.
I'm sorry. We're not having one. So I had to scramble. And because I was and when I started then looking for jobs, I said I wanted to be a cerebrovascular person. They said, well, you know how to do epilepsy. And I thought, yeah, of course, who doesn't?
Yeah.
But you have to understand where we were, right? This is the 80s, the mid 80s.
Yeah.
And we didn't have the internet. You didn't travel all around the world.
Yeah.
You thought everybody, you knew your own little world, and you thought everybody's world was the same. So, I would do 100 and 120 epilepsy cases a year.
Wow.
That's what we would, resections, and you sort of thought, well, that's what neurosurgery is. And we do tumors and spine, everything. But so then I realized, well, they really want an epilepsy surgeon. And my first job was here in Boston at Beth Israel.
Yeah.
And there were 2 other neurosurgeons who had both been trained at the MNI.
Okay.
The head of neurology was trained at the MNI. The neuroengineer was a guy named John Ives, who was brilliant. He was from Montreal. So it was very easy to come in, and they wanted me because I knew how to do a lot of stereotactic procedures and stereotactic depth electrodes.
Yeah.
And so my first job was in Boston, and my wife was from Boston. So it just made perfect sense. And so I arrived and did that.
Sounds good. Yeah. Okay. Another guest question from John Ralston that I think fits in quite well here. What advice would you give your younger self when you were just getting started in your career?
Yeah. It was a different time. I think and knowing what I know now, one of the great things about neurosurgery back then is that you got to do everything. I clipped aneurysms, did spine, did epilepsy cases, took out tumors, took out AV. It was wonderfully diverse.
Yeah.
And I loved that because we get to operate anywhere on the nervous system. And I continue to like that throughout. I love being all the different kinds of surgeons. I think I'm a very good surgeon, and I just love the variety.
Yeah.
Probably looking back, if I really wanted to have a stellar academic career, I would have focused more on one area. But I just loved
you would have missed a lot, right? I guess.
Well, I think that's right. And it's a bit like playing multiple sports. You get know more and more about less and less. So, and if you're only doing the same thing over and over again, you can become very expert at it, but it's not as much fun, and maybe there's not enough overlap. So probably would have concentrated a little earlier and defined my research areas and my publications more in one area, but I didn't. I loved it all.
Yeah, sounds great. If my research is right, and it could well be wrong, but you may have overlapped with Frank Irvin, who's a psychiatrist at McGill, who by the time had
he was
to research. I think.
Yeah, he was. I think at the Allen Memorial, and so was that at McGill or was
at McGill? Before, after. I think he had been at MGH, but then at some point, roughly overlapping with you, he would have moved to animal research only.
Yeah. I never knew him, and I just knew his book. What I did overlap with Vernon Mark.
Yes.
Not overlap, but when I was chairman at Brown, he had retired and he moved to Little Compton, Rhode Island, but he asked me if he could come to neurosurgery grand rounds when I was chairman at Brown.
Oh.
And I said, of course.
Yeah.
And he would come, and he was a very dignified and elegant man as well. And he just came to learn, which is great.
Wow.
Post-retirement, and we had some conversations around some of my work that I'd done previously at the MGH.
Got it. And but you did not overlap with him at MGH?
No.
Yeah, got it. So you have been in functional neurosurgery for a long time and have been there in the pre-DBS era, right? So you are probably among the few
good old days,
among the few practicing neurosurgeons who have vast experience in brain lesions for both neurologic and psychiatric disorders. Could you talk a bit about the beginnings of this journey for you? Maybe share even patient anecdote, or if there's a remarkable case you imagine. Yeah.
So I've been around a long time, and I learned how to do thalamotomies with plain X-rays and ventriculograms.
Yes.
That's how we did our thalamotomies. And people don't understand that thalamotomy was one of probably the most frequent operation performed by neurosurgeons in the 60s, and the 50s and 60s.
Yes.
So it was a standard operation, but we did it with plain X-rays and ventriculograms. Yeah. So, I saw how, and it took us all day, right?
Okay.
Awake patient all day, and we did everything from first principles, right? You had cut film, you marked it, you used your rulers on it, you measured everything, you did your calculations. It was an all day thing. It was really.
This was frame based already, right?
Yep, frame based.
Spiegel Weiss and used it. Okay.
So we used what we called the Olivier Bertrand Tipel frame because most people were making their own frames. They weren't the commercial industry. So we had our own frame in Montreal.
Yeah.
It was a modified Lexel frame, and that's the one I was trained on.
Yeah.
But so that's how I learned how to do thalamotomies from Dr. Bertrand. He was a master. Yeah. He could visualize the thalamus in his head, and I was just sitting there thinking, "How's he doing that?" It's the thalamic basal ganglia, capsular anatomy, and all those things. It's really hard to visualize, right? Yeah. Especially where we didn't have 3D images and being able to do all those things. So it took a lot. You have to have a good parietal lobe to figure that out. You have to study it carefully. Yeah. But I learned the basics from him. And then, of course, then we started, CAT scans were introduced in the late 60s, early 70s, and then MRI in the 80s. So these imaging tools have now got incorporated into stereotactic frames. But until the mid 90s, DBS wasn't around. Yeah. Right. So everything was done with radiofrequency lesioning. Yeah. Dr. Bertrand used a leucotome.
Oh, wow.
Which is which is dangerous because it's a wire. It's like a cheat. Yeah. You put out a little wire and you can spin it, and that cuts a little sphere. He used it because he understood the anatomy so well that depending on his first pass, you could steer it you could make a half sphere if you were a little too close to the capsule based upon your stimulation. Do you see what I mean?
Yeah.
Whereas if you do radio frequency, it just, it's concentric. It's like a VTA, dangerous. Right?
Yes. And it's dangerous because of vessels.
Yeah. You got tiny little vessels everywhere. So you have a much higher risk of hemorrhage. So I never used a leucotome. Yeah. I used a Siegfried side exploring electrode sometimes, which could go out and you could push it in different directions. It was fun.
Directional stimulation.
Yeah. Directional stimulation. Yeah. And, but I always used radio frequency.
Yeah.
And, but by the time I started my own practice, people weren't really doing thalamotomies anymore because they had just died out.
Okay.
There were occasional patients that I would do.
Was that because of levodopa?
Yes. Yeah. And all the different medications.
Yeah. Okay. So it was mainly Parkinson's for thalamotomies.
We never did pallidotomies in the neuro. It was all thalamotomies for Parkinson's and for tremor. Yeah. But it wasn't until Leitner. So I left Beth Israel and to go to UVA.
Yeah.
And John Jane, his story is that he delivered me because he was an intern when I was born. And his story was that he was pretty sure he delivered me. So that's why we had this connection. And John and I, we had a long connection. But he recruited me to go to UVA to set up an epilepsy surgery program.
Yeah.
And so I went there because I knew how to do epilepsy surgery, all of that stuff. Yeah. And then after a couple of years, just 2 years later, we moved back to Boston. But where were we going with that? Oh, it was only in around 1992 when Rees and Lightning came out with the posterior ventrolateral pallidotomy. I said, "Ooh, this looks fantastic."
Yeah.
And so when I went back to the MGH to set up their surgical epilepsy program, because they never believed that epilepsy surgery was worthwhile.
Okay.
I set that up with Andy Cole. Mm-hmm. Andy and I were residents at the MNI at the time, so we knew each other. We had the same thinking. We knew exactly what to do. So we set that up. But then because I was a so-called functional neurosurgeon, I thought, "Oh, this is something that really is impressive."
Yeah.
And so I started doing
how
pallidotomies.
Did you see that? You mentioned there's no internet. So you saw it at conferences?
You read it. Remember, there are things called journals and articles, and you read them.
Yeah. Okay.
You read them.
No, I get it. But that wouldn't, with that, you wouldn't see, let's say, a patient video or anything, right? No. But if you understand, the anatomy and you understand the patient population, and the results were so good. Yeah. Okay. Or at least in the paper. Yeah. And these are trustworthy people, right? Sure. Rees and Lightman. Yeah. Right. And I'd never met Marwan Hariz at the time, but I was so impressed with the paper. Ooh, get this. I wrote them a letter. Oh, you did? I just said, I was so impressed with your paper. I typed out a letter and sent it to them. Fantastic. And that's how Marwan and I and Lori Lightnin and I started a relationship, Wow. And that was the second advent of the pallidotomy, right? So they kind of reopened that field that it used to be done before too, right? In the 50s, 60s. Yes. But then, okay. And Lexell always believed that the pallidotomy had a better effect than the thalamotomy. And it was a shift. There was a shift. The understanding some of the anatomical connections and Hassler doing his anatomical stuff, the suggestion that thalamotomy should be better. Okay. But in a conversation with Lightnin, he said, Lexell, he couldn't go against the tide, but he always felt that his pallidotomy was better than the thalamotomy in patients with Parkinson's disease. It's sense. So interesting. It's very interesting. Yeah. You only get these in conversations. You only get this kind of insight in conversations. That's what I'm trying to do. Yeah. No, absolutely. So, and then I guess you set up your own shop at MGH to build the epilepsy program there, and you spent 13 years there as head of epilepsy and functional neurosurgery. And then you did tell me once about this remarkable coincidence involving this electrician patient, I think. He was an engineer. Yeah, an engineer. Who needed a pallidotomy, or maybe you can tell. You can't make this stuff up, okay? You can't make this stuff up. So I'm back at the MGH now and doing pallidotomies, and mostly epilepsy, but now I was interested in a pallidotomy, and I teamed up with Jack Penny, who was Ann Young's husband at the time, and I said, are you interested in? I'm interested in doing these things. Would you be interested in? And of course, they were a little leery about it, right? About pallidotomy. Sure. Well, they were about surgery in general? Or surgery in general. Okay, but their model was a good model. I mean, it was the right model. Yeah. But they were a little leery about, neurologists are always leery about making little holes in people's brains. Sure. There's somewhat appropriately. So I said, let's start this. And I said, you will admit them to neurology. I'll do the surgery. Yeah. You'll follow them and you'll rate them. Yeah. And, it was a bit risky, but, I said, this is how we're going to do it. So I started doing a couple. And again, this was both CT and MR guided. Yeah. It took most of the day because you had to get
a CT with the frame on and an MR with the frame on. And then there was a CT adapter because there were some inaccuracies in the frame. We had to figure that out. But I would do direct targeting, no microelectrode recordings.
Okay.
And I did it all with macro stimulation and really good targeting.
Yeah.
Okay. Anyway.
Was that already software based at the time or?
No.
Okay.
It was just literally on the screen, making our measurements, making little tiny adjustments. No atlases, we have atlases, but they could, if they weren't good.
But you could register in the computer, the two images with the frames on.
No. You just did it on the individual, and you sort of calculate it on one and calculate it on the other, make some adjustments, and then set the frame to the target, and away you go. And you would confirm with macro stimulation thresholds, motor thresholds, visual thresholds, and various things. And I mean, that's how I learned how to do it my way, at least. Never used microelectrodes.
Never, ever?
Not for thalamus or pallidum because of the risk of bleeding.
Yeah.
And I had one case where I did one and I had a hemorrhage in the thalamus on the table, and so there are extra risks. And for the STN, I always used microelectrodes because it was a target you can't see on a T1 weighted image, you see. And that's all we had. Yeah. We had T1 weighted images.
Okay.
That's it.
There was no T2 at the time?
We weren't sure that it was accurate in terms of...
makes sense.
So we knew that T1 was probably accurate.
Yeah.
Anyway, so I'm sitting with a lovely Raytheon engineer and his lovely wife in my office, and he has young onset Parkinson's disease and very dyskinetic. Mm-hmm. And we start talking, and he's an engineer, so and I thought he would be a great candidate. And then his wife leans forward and says, "Well, how many of these have you done?"
These surgeries, yeah.
These surgeries. I said, "Well, 3."
Yeah.
And she looks at me, and he looks at me, and he says, "Oh." And I said, "Well, if I were you, I'd go to see Laurie Lightnin because he's the world expert on this." Yeah. And Laurie at the time had an international practice where people would fly into Stockholm and go to the Karolinska, and he would do his procedure. And so they left my office, and I had no, I said, "It's up to you. I'm happy to do it here, but you could." So it just so happened that the ESSFN, the European Society of Stereotactic and Functional Neurosurgery, in that year was in Stockholm. Mm-hmm. And since I'd had a correspondence with Laurie Lightnin, never met him, but had a correspondence, I wrote him a letter. Yeah. And said, "Would you mind, I'm going to be in Stockholm, would you mind I come a few days earlier? Yeah. And observe you doing a pallidotomy?" Yeah. And he said, "Of course." So I go a few days earlier, and he's showing me his technique. We meet and he says, "Well, we'll go down to the patient now." And he had a little localizer. He did the imaging the day before. And we go down to meet the patient. And who is it? My patient from Boston.
It's so funny. Yeah.
Yeah. You can't make it up,
he
right?
must have thought this can't be happening.
No. Yeah. Yeah. Anyway, so then the next day we do the pallidotomy, and it was, Lightnin was an elegant guy and very simple instrumentation, ding, 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 ding. But, I'm learning the whole time from the master. Mm. And the patient does really well. It looks great. Mm-hmm. Leaves the hospital the next day, has a wonderful, his dyskinesias and the rigidity is gone on that. He was pretty lateralized at the time. And he's elated, and I'm thinking like, this is magical. Yeah. And I said, "This is great. I'll follow him for you." Mm-hmm. Anyway, so I follow him up, and 7 to 10 days later, the dyskinesias start coming back. Mm. So I see him. I wait a couple of months, and now he's almost back to where he was. Mm. I get an MRI scan pretty soon afterwards, and it looks, and I now I have the films in those big manila envelopes. Yeah. And there's no internet. Yeah. So I take pictures of the films. Yes. And I send them to Laurie, and I say, "I think your lesion is too anterior." Yeah. And he looks at the films, and I think we had a phone call after that. Mm-hmm. He says, "You're right." Mm-hmm. So then I say to him, "Well, he needs to be reoperated on." Mm. And I said, "Well, this is great. I will invite you to come and give grand rounds at the MGH. Yeah. And after the grand rounds, we'll go do this procedure and you can watch me doing the procedure. And, anyway, so here's the same patient we're operating on. I put the electrode down onto the target just posterior to where he was. He was too anterior, which was typical for pallidotomies that are too anterior. They don't work over the long term.
Yeah. Okay.
You have to be right near the outflow tract, the pallidal fugal fiber outflow tract. Right? And so I put my electrode down and I'm stimulating. I do my way of doing it. By then I'd done probably a dozen.
Yeah.
Okay. So I'm not exactly expert yet.
Yeah.
And we get down to target. I stimulated high frequency and the guy starts going wild on the table. Just movements all over the place. And my eyes open up and I'm thinking, Jesus, if I make a lesion, he's going to be permanently dyskinetic. And Laurie Lightnin leans over and he says, "Oh, this is so good." And because if he hadn't been, because he says, "This is good, he will do very well."
Yeah.
Okay. And so because he was standing there, I lesioned him.
Yeah.
And literally this guy had, for 25 years afterwards, had great contralateral control. And I eventually did a stage bilateral on him.
Oh.
But, you can't talk about serendipity.
Yes.
Right?
Yeah.
And
so
coincidence.
It's this, and we discussed about that when you told it first, when Ludwig was here, that you now use that, like people use that as a marker, right?
Yeah, but I didn't know. I know. Experience, right? But if you get that and you see that with high frequency stimulation.
And it's high frequency.
It's high frequency, not low frequency. When you do motor thresholds and various things, you're losing at 2 hertz, low frequency. And for sensory and for visual, you use higher frequency. But this is
so interesting because it speaks against DBS being the same as a lesion. As we know, it is not, right? It's not exactly the same, certainly, but it still mimics a lesion. But in these acute phases, it seems different, right? It's the same frequency or like above 100 or so.
Yeah, about 130.
And then interesting that you have these onset effects that make people dyskinetic before making lesions.
Yeah. I think DBS mimics lesioning in certain targets. Okay. And maybe in certain circuits.
Yeah.
But in certain targets, the physical result is very similar.
Yeah.
But that's not true in all targets or in all circuits.
Do you have clear targets where it's not the case?
Oh, white matter. For sure.
Okay. Right. So capsulotomies, you mean, for example?
Well, we don't know. We don't know. But I mean, my best example is fornicele stimulation. If you lesion the fornices,
that's not
going to be the same. Right.
Makes sense. Yeah.
But so I was elated because I had so much experience with radio frequency and how good they are.
Yeah.
And simple, right?
Yeah.
You have to be a better stereotactic neurosurgeon because you have to be absolutely accurate in your targeting and your technique, right?
It's permanent. Yeah.
DBS is forgiving, if you're a little off, then maybe they don't do as well, but but I mean, to be a good DBS surgeon, you have to be absolutely accurate as well to get the preferred result, clinical outcome. But with lesioning, you have to even be better.
Yeah.
And, so I was a sort of a late adopter to it because, I had such experience with lesioning and, I didn't start really doing DBS until the mid 90s.
Okay. Yeah.
Which is a little late to the table.
Yeah.
But the beauty of DBS, of course, is that you can do it bilaterally.
And you can still adjust things, right? So you can kind of react to the disease progression and it's more forgiving. That's also a feature, right? Of course. Yeah.
Yeah.
Okay. So many questions, that I have, but the MGH had a long history of functional neurosurgery, also including psychiatric indications. We did briefly mention Vernon Mark, who I think retired 1988 there. And there's a guest question from Clemens Neudorfer who remembers you once saying that, about the rise and fall of psychosurgery at the time.
Yep.
That there may even have been protests on the street.
Yeah. So when I went to the MGH, I was the functional neurosurgeon.
Yeah.
And Dr. Tom Ballantyne, who had been doing these procedures for years and years, had retired.
Yeah.
I think Chris Ogilvie, Bob Martuzza, even Nino Kioka here did some of them. But nobody wanted to do them. But it was just because there was an evaluation process, and this had been going on for 25 years.
Got it.
I never believed, I was sort of like everybody else. I didn't believe that you could do this correctly. Psychiatric surgery. Yeah. I was quite cynical about it. And when I got there, they said, well, you'll take over the cingulotomy program. And I'm going, I don't know.
Yeah.
I really thought I had too promising a career.
Yeah,
that I didn't want to be my reputation sullied by this.
Sure.
So the only thing I did differently, so then I said, well, I will observe how, the process. And I said, if I'm going to be involved in this, we're going to do it the way we do epilepsy surgery and movement disorder surgery. Yeah. And the only thing I did was I introduced MR guided stereotactic cingulotomy because Ballantyne didn't use stereotaxy.
Okay, wow.
He had a fabulously interesting technique, but he used plain X-rays. Okay. So I said, at least I know I can make reproducible lesions where they should be, at least where we think they should be. We don't really know.
Sure.
So then I said, okay, and then I got involved, and it became one of the most fascinating and interesting portions of my career, I have to say.
I'm sure, yeah.
We would only do 10 to 12 a year, like one a month. But it was really remarkable. The surgery is the easiest thing about that. For a stereotactic surgeon, doing cingulotomies is easy.
Yeah.
I evolved. I didn't know really what I was doing. I just did it the way Dr. Ballantyne did it, but with MR stereotactic.
Yeah.
And then I just followed, learned, and that's when we started doing multiple lesions at the same time, because many patients had to come back for second or third lesions. And then we evolved it into, said, well, then we started doing limbic leucotomies in the patients that hadn't responded appropriately.
Are there any cases you remember vividly?
Oh God, there are some unbelievable cases where some of the worst cases were where luckily I had gotten confident enough to do a limbic leucotomy, which is a combined anterior cingulotomy and a subcaudate tractotomy. Yeah. The subcaudate tractotomy that I did was really also took out the ventral capsule, anterior limb of the internal capsule. But we had a cohort of patients with severe self-injurious behavior. And there are a couple of patients. One I remember who was shipped from New York in a padded cell, and who basically, anytime somebody touched her, she would bang her head or bang her arms. And so her back of her dorsal aspects of her hands were just granulation tissue, and you could see the tendons because she wouldn't let anybody.
God. Yeah, yeah.
And so we performed a limbic leucotomy on her with major benefit.
Wow.
We had a swallower who had about 350 operations for swallowing. She single-handedly trained a whole generation of general surgeons with endoscopic technique.
Okay.
Because she'd had about 250 endoscopic retrievals of foreign objects and about 120 open operations to take out objects that she had swallowed.
Wow.
This woman was institutionalized with 2-on-1 care for years. And she had a complex psychiatric diagnosis, as all these people have. But this woman, after we did the limbic leucotomy, slowly gets better, stops swallowing. Yeah. Eventually, she had been institutionalized since the age of about 15.
Yeah.
Eventually gets out, starts living independently, gets her GED.
Wow.
Gets a job.
Wow.
That's fantastic. You can't make, you can say, well, it doesn't work, right?
No,
well, it does.
Yeah.
And we had multiple patients, who you don't cure people with psychiatric surgery in my experience, but you can make them substantially better where there's nothing left for these people.
Of course. Yeah.
So there were many cases of that sort that were, really almost unbelievable. And I had another patient who, 18 years afterwards, calls me. She had been institutionalized with self-cutting, burning, and various things. And she calls me and she says, I had a seizure. Mm-hmm. And you remember these people's names, right? She calls me and had a seizure. I said, well, how did that happen? Well, this woman who had been institutionalized for years and years and years with 24-hour one-on-one care was getting her master's in wildlife biology, and she was on a field trip doing some of her research.
Oh my God.
And she had forgotten her anti-seizure medications.
Wow. Oh my God, that must be very rewarding to hear, right? I know it's individual cases and also very devastating life stories, but like if successful, this changes lives.
It changes, yeah.
And then you briefly mentioned cingulotomies, subchord tractotomies, and then capsulotomies.
Yeah.
Is it easy to summarize which you would do in kind of which patient, or was it more like historical evolution of it?
If you look at the literature, the capsulotomy seems to be better for OCD patients.
Okay.
I did some capsulotomies with radiofrequency. When I was at Brown, I was involved in the gamma knife capsulotomy experience down there. Those guys have a huge experience.
Yeah.
The safest of all these procedures is the cingulotomy because it's more cortical.
Sure.
Okay.
Yeah.
And it really has an amazing safety profile. And it works probably for somebody with depression. I would use cingulotomy as the first instance. And then if they failed to respond or recurred, I would convert it to a limbic leucotomy. If the cingulotomy for OCD is very good as well. Mm-hmm. And I think the side effect profile is much better than a capsulotomy, at least the way I did it with radiofrequency.
Yeah.
I think what's the issue is the gamma knife seemed to be safer, but that was because the lesions were created slowly over time.
Yeah.
And I don't know whether, and how much of it is, injury to contiguous structures, expansion of your lesion into the head of the caudate and anterior putamen. And as where there's a laminar organization to in the anterior limb of the internal capsule. Yeah. What are the important pathways or circuits that you're trying to affect? There's circumstantial evidence that some portions are necessary. This is
totally agree.
And I think with focused ultrasound, we should be able to work that out without any instrumentation of the brain,
because we can test sonicate as well, or
we don't know if LIFO will be able to test sonicate or not in white matter like that.
Sure.
I think it's probably true in gray matter, but I'm not sure it's true in white matter.
Yeah. Another guest question from John Ross. And
John,
what do you that fits here? What do you see as the ideal patient for ablative surgery in psychiatry versus newer treatments like DBS and TMS?
So, I think I've always been a proponent of ablative surgery because in psychiatric disease because there's so many parameters that we don't understand, with DBS, and with even with ablative surgery, there are no acute effects.
Yes.
Okay. You don't see improvement in their psychiatric makeup or their psychiatric symptoms until you're 3, 6, 9 months out.
Okay.
Okay.
Yeah.
Because you have to think, and so if you're playing with stimulation parameters and doing all these things, there's no immediate effect. It's not like tremor that, I got it.
Sure.
Right? Everybody knows this. So in the real world, you can't have all these people with DBS electrodes in and you're stimulating it. The work is ridiculous. Okay. And the overarching positive placebo effect of having a group of experts working on you, month by month and all these things, you'd have to feel pretty good about yourself, right?
Sure.
This was the problem with the trials.
Yeah.
The real world is that you have these people in different parts of the country, and this is what they would be sent to us at the MGH.
Yeah.
And you get a chance, you do an intervention, and then you send them back to their environment with their psychiatrist. They were always referred by psychiatrists. Okay. Yeah. And if you do an intervention and then you have to wait, and then, we had patients who were non-responders at 2 years.
Yeah. And
then became responders by 3 years.
Okay. Wow.
From a procedure that was done 3 years earlier. Mm-hmm. Now, that means it's not the same way we look at surgery, functional neurosurgery, that you do something, you have an effect, and it's done, right?
Yeah.
It's very different.
Yeah.
But that's the real world.
I guess a lesion has this one and done, like you don't have, the patient doesn't have to be compliant, right? Later.
Correct.
That might be another.
Well, they have to be compliant in the other treatments that they're still receiving. Right?
Sure. Yeah. No, but they don't have to go to the DBS visits as much and these things.
Right. And all these things changing, and is this going to work? Is this not going to work? Yeah. So I think it's more pragmatic and practical. Yeah. So I think if we had, that's why I still believe that if we understand the exact targeting for the different diseases, then this would really provide overall for societal benefit and patient benefit. It'd be much more practical and useful.
Yeah, makes sense. Right. After your time at MGH, you became chair of neurosurgery at Lahey Clinic and then chair at Brown University. Yeah. And at Brown, you reorganized the department, recruited 2 new faculty, Drs. Wael Azad and Albert Talfayan, and were instrumental for the establishment of the Norman Prince Neurosciences Institute. Can you talk about your time at Brown a bit?
Yeah, so I probably made a mistake by leaving the MGH to, that was ego saying, when you think you're a powerful person in neurosurgery and we train our residents, so you want to get
to become chair,
right? Okay. That's the eventual accomplishment. And at the time I'd been looking at some chairmanships, but my wife didn't want to move from Boston. And I said, I made her move a couple of times before. So I said, well, the chair at Lahey, and I had the somewhat naive thing that I could make Lahey into a proper neurosurgical institute. Lahey has a great history of neurosurgery. Okay. Frank Lahey, was a great neurosurgeon. He wasn't a neurosurgeon, but they had a good reputation, that's when I became more like a general neurosurgeon because Lahey does general neurosurgery. Yeah. It does everything pretty well, but I did tumors, and spine and all those things. So, and I realized after 5 years that we didn't have we had one resident from Tufts, and this was not my milieu that I enjoyed. It wasn't truly an academic place. Yeah. Good place, but not an academic place. Yeah. And then they offered me the Brown chair. I didn't come up with the part of the attraction was that they had this tranche of money of $25 million from the Prince Family Foundation to create a neuroscience institute. And at the time, and still to this day, Brown Neurosciences is one of the strongest departments at university. Yeah. I was pretty naive about going there as well, thinking, this would be easy. You have Rhode Island Hospital with a neurology and neurosurgery, and Brown. The problem was that they didn't like each other. They didn't really talk to each other. It was more of a town and gown kind of thing.
I see. Okay.
But I had multiple meetings with John Donahue, who was head of neuroscience department. Yeah. Just retired, but was doing all the brain machine interface. And we got along really well. And I thought, this is fantastic. We'll just get these things working together. And I think we made a lot of progress. Yeah. But, that that job nearly killed me.
Okay.
I was commuting back and forth, and
you lived in Boston, or
my family didn't leave Boston.
Okay.
I had a place down in Providence, that I'd stay down there during the week, come back on weekends. Sometimes I'd come back and forth, and again, I tried to be the neurosurgeon. Yeah. And show everybody how great a neurosurgeon I was. And so I did a lot of surgery. And because if you're trying to lead a group of neurosurgeons, you have to show that you're a good neurosurgeon yourself. And there were some issues in the department at the time. And, but we made some real progress and established, the foundation for further success, and they've had a lot more success since I left.
So in 2015, you moved back to Boston.
Yeah.
Probably relief on the private side and no commuting anymore, right?
Yeah.
And became director of Epilepsy and Functional Neurosurgery at the Brigham. And there is a lot of history in neurosurgery surgery here at the Brigham. For instance, Harvey Cushing practiced here, who is often considered the founding father of the field. I think you once received the painting of yourself from a very gifted patient that you operated on, who also commissioned a painting of Cushing that can now be seen on the fourth floor of the Hay building that we're currently sitting on. There are also, close to this painting, there are memorabilia from Cushing and others. Yeah. Can you talk a bit about, these artifacts that we still have here, things that are most precious?
Yeah, so Harvey Cushing really was the founder of modern neurosurgery, and he spent all his formative years here.
Yeah.
Like all great persons in history, their presence gets eroded over time with progress. And here we are, and you can hardly find a portrait of Cushing anywhere. And
just visited the center in Yale where they have this whole.
The Cushing Library, very good. So Harvey Cushing left here and sort of just.
He was retired already, right?
No, he was. I don't think he was retired. I don't think it was an amicable parting. But so he left and went to Yale and took all of his library and all of those things to Yale. And, but, still, this is where it all happened.
Yes.
This was where modern neurosurgery really happened. He was a master surgeon, very demanding man.
Okay. Did you overlap with him?
No, way long ago. I mean, Wilder Penfield was a dresser for him in the First World War.
A dresser?
Like a wound dressing, like he went to, and then Wilder Penfield, he was actually, he was on a ship that was torpedoed and was injured.
Yes, I remember.
And then he was picked out of the water, had his leg set, and then he lived with Sir William Osler in Oxford, for several months. And that's where their connection occurred.
Yeah.
Anyway, So I had this patient who was a gifted artist who had essential tremor. Yeah. And he couldn't paint anymore. Yeah. And I did a focused ultrasound thalamotomy on him. And he said, well, if this works, I'll paint your portrait.
Yeah.
And I'm going, oh, Jesus, I didn't know he was a gifted painter, right? Because you could sort of imagine some sort of scary looking portrait. Yeah. But he several months later, he ships this portrait to me. And it's fabulous.
Yeah, I see it. It was fantastic. Yeah.
Yeah, it's in the residence room. Okay. It's because I have to I'm the program director, so I have to keep an eye on the residents. So my presence is always there, so they behave. Yeah. But when I was so impressed with his work that I said, then I commissioned him, because there's no painting in our department, and so I got permission from the Harvard Fogg Museum for this original painting. And I said, can you do a reproduction of this? And that's the painting that is out there to sort of, and then some of his memorabilia, some of Cushing's original operative descriptions are there. Some of his tools are there. Yeah. Just to sort of say, this is where we have come from. Yeah. It's very important.
It is. Yeah. Cushing wrote a biography about Sir William Osler,
Yes.
for which he was awarded the Pulitzer Prize.
Yes.
So talk about talent, right?
Yeah. Well, Cushing wrote daily.
Okay.
Cushing wrote every day. He wrote. So he had amazing energy. And, so even when he was operating and doing 25 craniotomies in the First World War, every evening he'd sit and write and document
about
what he had seen and various things. And I remember reading one of his books from that experience. It was amazing. He used huge magnets to try and pull shrapnel out of people's brains.
Oh, really? Wow.
Which is not such a great idea when you think about what shrapnel looks like and you're trying to pull it out. But it's a bit crazy, but novel.
Yeah. Okay. And is there any relationship you have with Osler?
Yeah. So Osler was a distant relative of my mother's. So, and Osler, where my family lived in Westmount in Montreal, Osler had lived his original home, which was modest. Yeah. Was around just up the hill and one street over. Okay. So my mother would say, "This is where Sir William lived."
Wow, so it's all connected in a way.
Yeah, it's all...
Okay, so the two of us first met when I was a postdoc with Mike Fox. I was still at BADMC, and you kindly allowed me to come across the street to watch
a procedure, right?
DBS case.
A DBS case.
With you in the famous Amigo suite.
Amigo suite, yeah. I remember this, and you were with your wife at
Yes,
I'm not sure she was your wife at the time. It was your first...
Absolutely, yeah. No, you're right.
You were just a kid.
I was a kid. That's true. And so that was like, I even went to Germany back.
I remember
forth, right? So, but it was ages ago. But you mentioned you changed to intraoperative MRI, and the Amigo suite was probably one of the key reasons to be able to do that.
Yeah.
And to sleep surgeries, and you were never going back.
Yeah.
So this is now a great guest question again from Melissa Tour that fits well. How did you adapt to modern day techniques from, thinking about ventriculographies to MRI guided, and your view of where you think technology in functional neurosurgery is going next?
Yeah, it's interesting. A lot of what I do today, I was never trained to do.
Sure. Yeah.
But again, circumstances and serendipity and opportunity. Okay. Yeah. So I come back here to the Brigham, and I don't have a lot of operating time, and I had, but there was this really, the Amigo suite, which, is, I call it the surgical expensive care unit.
Yeah.
Because it has so much equipment, right?
Yeah.
So many people. And I didn't believe in intraoperative MRI and the ClearPoint system, because I thought, how could that? I was so experienced with a rigid metal frame, and I thought, how could an extruded piece of plastic be accurate enough to do what we're trying to do here? I said, it makes no sense to me.
Yeah.
My mistake was I didn't investigate it properly with an open mind. I made a judgment call, and I said, I'm not going to do that. Yeah. That's ridiculous. So, but when I came here, I didn't have any operating time. Mm-hmm. Because,
ORs were full.
ORs are, nobody's going to give up their operating time to a new guy, even if I'm old. Certainly not an old new guy. Mm-hmm. So, but then I saw this operating, and it wasn't being utilized fully.
Okay.
And then I thought, well, if there's anybody who should make a judgment about whether this is a good way of doing it or not. Because I'd had intraoperative MRI scans at the General. We had a little small one. I said, don't let me ever use this thing again. It just slows you down. And I still think that's true in most intracranial stuff. It just slows you down, and it has marginal benefit, and it takes a ton more time. But I thought, if there's anybody who could ascertain whether this is useful and good, it's probably me, because I don't believe in it in the first place.
Yes.
And so I did my first case probably a few months after I got here.
With ClearPoint.
With ClearPoint.
Yeah.
I did go out and observe Paul Larson in San Francisco do it, and saw him do a couple of cases. And I thought, okay, well, Paul knows what he's doing. Yeah. And I really looked at it more carefully. And I said, okay, I still didn't trust him. Yeah. But then I did my first case, and I thought, oh, yeah, this can work. Mm-hmm. And then I'm a complete convert. Yeah. And so it's an example where technology really it makes it more accurate. Yeah. It makes it safer. Yeah. And more comfortable for the patient. Mm. That's not the reason I do it. Sure. Not for patient comfort, but you can control the patient's blood pressure perfectly throughout the whole procedure. Now our imaging sequences are so good now. Mm. It's not just a T1 and hope that you get it in the right spot, right? We have imaging sequences that you can see your target. So it's direct anatomical imaging. Yeah. So human stereotactic atlases are your starting point. Yeah. So you need to know what your basic coordinates are, and then you refine it for individual anatomy, and you can see the target, and then you don't make any passes. This is the key, right? Yeah. You don't make any passes until everything's perfectly lined. Then you pass it with a ceramic stylet so it doesn't interfere with your imaging. Yeah. Then you confirm you're on target. Yeah. With the MRI. And then you afterload the electrode down the peel away sheath. And, it's remarkable. I'm very good at this. I've done hundreds and hundreds the old fashioned way, DBS, right? But I've never had to make a second pass with this. Okay. Yeah. You can have a bad day. You can be an expert and have a bad day. No, you can make. Now, there's still little errors that you can make, of course, like anything. Complicated procedure, but you can't be that precise and accurate on case after case after case. We do 2 cases, bilaterals, done by 5 o'clock, basically. It's efficient once you have a team that understands the working and the operating environment. So
you mentioned you've never been trained, and I think I remember when I was there, it was 2016.
So it was pretty soon on, right? It was just shortly after a year after I got here.
And I think there was an ebook from the Star, like Philip Starr was one of the authors.
Yeah. Paul Larson and Phil Starr. Yeah.
So essentially this free ebook that's still available. I checked when I interviewed Phil, and where this is described, right? And you had to kind of learn it, like not the surgery, of course, from scratch, but the
technology. And I think that they were brilliant in doing that, because that's the way books should be now. Yeah. They should be ebooks with embedded videos, embedded imagery. This is the new knowledge book, right? Yeah. It's not just paper and pictures.
Great. One guest question from Mike Fox.
Oh, dear.
The number of neurosurgeons with classic lesion experience is shrinking at a time when lesions are making a comeback with focused ultrasound. How do we preserve this experience and prepare the next generation?
Yeah, so you've heard of, so this is true. Well, especially true in the developed world. Yeah. Okay. In North America and maybe Europe. So functional neurosurgeons were never trained to do lesions. It was all DBS, if you think about it, right? Yeah. So from the early 90s to now. So that's, basically, let's say mid-90s, 30 years. Yeah. That's more than a generation, okay? So you have a generation of functional neurosurgeons who only know how to do DBS, because that's what they saw. Yeah. So over 10 years ago, a dozen years ago, Marwan Hariz, myself, Jean Regis, and Takayoma Tara, who's a master legionnaire from Tokyo. Yeah. We said, this is a lost art. And I think it was over drinks or something one night. We said, we need to educate neurosurgeons around the world with how to make lesions. So we came up with this course called The Noble Art of Lesioning. Oh, wow. And we call ourselves the old legionnaires, but it really is to train people again on all the principles of stereotactic and functional neurosurgery, but instead of putting an electrode in. We do indications and targeting and all those things, but it's really, so we have radio frequency lesioning, and we show people how to do it in egg white, and how you use the stimulators and so we put this on every several years in different places around the world, rotating. And the next one will be back in Marseille in June.
Oh, okay. I don't know. That's fantastic.
Yeah. And we do this. We've had it in Boston. We've had it in Marseille before. We've had it in London. We've had it in Tokyo.
Yeah.
And what's interesting is that the people that are coming are usually from Africa, Asia, Eastern Europe, where they don't have the money to put in DBS electrodes. It's too expensive, right? The equipment alone is like 50.
Latin America, people still do that. Lesions as well.
Yeah, we have them from Latin America too. And
then the London group, like from the more, of course, developed world, they have.
Well, that was Marwan, right? And Marwan influenced Ludwig, and I mean, they're just really good. Yeah. They're comfortable with it. So it's not a dying art. We're slowly resuscitating it.
Yeah.
But and then of course, focused ultrasound comes into play.
Yeah.
And it's ideal. Well, not ideal, but it's brain surgery with sound.
Yeah.
And therefore you don't have to instrument at all. So that is the danger is that you still have to put a frame on and various things for HIFU, but, and you have to be an excellent, functional neurosurgeon in terms of targeting experience and lesioning, but that too is too expensive for the developing world.
Yeah. Will it be at the WSSFN in Marseille? Is it?
No, this is a separate course. This is a 2-day course, and it'll be 50 people, 50 to 60 people, all neurosurgeons.
Got it. Okay, so you are prominently involved in the focused ultrasound scene that has been taking off over the last years, and you certainly have been a pioneer now with, I think, over 600 cases done.
650, I think.
650, wow. And I think few would know that you've been a true pioneer, even way beyond that, because I think you and also the Brigham team here have been involved.
So here's another. I have nothing to do with this. This is another example of God, or not God, whatever you believe in. It was just circumstance and happenstance that I happened to be in the right place at the right time with the right experience. So when I arrived here, so first of all, focused ultrasound was developed here at the Brigham in 30 years ago.
Can you talk about that a bit?
Yeah. So Ferenc Jolez was a Hungarian neurosurgeon, fully trained, graduated from Semmelweis University in Budapest.
Yeah.
Okay. A famous university and medical school.
Yeah.
One of the famous big ones, right? Lots of Germans are educated there. In German. Apparently.
I know. That's for different reasons.
Maybe they couldn't get into the one. But anyway, so he graduated there and emigrated to the United States.
Yeah.
Comes here, he can't be a neurosurgeon. He'd have to go back and do 7 years of training. Mm-hmm. So, but he's a neurosurgeon, and he's trained and he's operated, and I think he was in practice for 5 or 7 years. Mm-hmm. And so instead of going back and doing his training, he said, I can do 2 or 3 years of radiology and become an interventional radiologist. Mm-hmm. But so he did that here.
Yeah.
And then he sort of said, there's this MR, and can we do MR image guided surgery? And he developed the big double donut, where you actually did neurosurgical procedures standing in these 2 vertical donuts.
Oh, wow.
Okay. And that patient's back or head was in the center, and you had a space for you to physically operate in the MR.
In the MR, okay. Wow.
That was called
that.
Yeah, that was a double donut. But then, he had his hands in a lot of things because he was thinking like a surgeon, but he had, and then he met Kalervo Heinonen, who's a Finn, who had been interested in ultrasound since he was a high schooler or a university, and had done all this work. And I think at the time he was in Arizona, but he's and he recruited Kalervo.
Yeah.
And then they started working on, could we do this in the brain? Because this had been done before in the 50s by the Fry brothers.
I know.
right? And
without
you had to take the skull off.
Yeah.
You had to take the skull off.
Yeah.
They had proven that you could do this. And the whole idea, because everybody was poking things into the brain to do surgery for movement disorders.
Yeah.
Could you do it non-invasively?
Yeah.
Well, taking off half your skull temporarily is hardly non-invasive, but it was extradural.
Yeah.
So, but anyway, they started, could we do this through the skull? Mm. And it was Kullervo and Yolez, they started working on this. Mm. Jason White, who is now a PhD physicist, graduated from the Berklee School of Music. I think he was the French horn. Okay. Wow. He's an expert musician. Couldn't make a living, obviously. Mm. Needs money. Becomes Kullervo Heinenen's lab assistant, basically a workie in the lab. Mm. And gets so interested in it. He's so smart. He's so interested in it that he says, I'm going to go back and get a PhD in physics. Mm-hmm. Okay. But Jason and his now wife were the first people they made the first 64 channel focused ultrasound helmet. Yeah. Okay. And then they had to buy the stuff off the shelf and connect it. They got a couple of MIT engineers to come over and do all the electronics for them. And then they actually created the first 64 channel. And at the time, GE's main office was here. So they were and the scanners they were working were GE. And so that the GE engineers and everything, they started working on all that. Yeah. And eventually GE got out of that business and they sold the intellectual property and the development and the knowledge to Insight Tech, and Insight Tech created the commercial device. Yeah. So I arrive here.
And Nathan McDonald played a role.
Nathan is a physicist. Yeah, exactly.
Because they are both around still.
Nathan is still here, and Jason's still here. Yeah. But Nathan came down and he had a PhD and was doing his postdoc. Yeah. With Kullervo. And then Nathan has become this guru of focused ultrasound in all domains. Yeah. He's absolutely brilliant. Yeah. So all of this stuff had happened, and I just arrive, without knowing it. Yeah. And I arrive and they say, okay, we've started this trial, that original, randomized, sham controlled, blinded trial of focused ultrasound thalamotomy. And I say, well, I can do this. Mm-hmm. You show me how this equipment works, right? Yeah. Because I understand this problem. And so I had nothing to do with it. I just arrived on the scene at a very opportune time. Yeah. And,
but you saw the opportunity and.
Oh, and I mean, you know.
all in, yeah. Yeah.
Yeah. I mean, I had been talking with the Insight Tech people before about what would be the best trial to do. And I had talked to them. I said, this would be the best trial. If this works, you're going to demonstrate that it works.
Yeah. Yeah. You did mention that with all your experience, you also tried pallidotomies and then subthalamic nucleotomies, I think.
I haven't really done a subthalamotomy with focused ultrasound. But I have done pallidotomies, and I don't like them. Yeah, I don't like it, and that's because it's technically just beyond the field. It's harder to do, and the geometry of the lesion we make with a focused ultrasound, it's not spherical. Yeah, it's ovoid and elliptical, and the orientation of it is exactly wrong for the GPI. Mm. It's not good for the thalamus either. Yeah. It's the wrong orientation.
I see. Okay.
But we can adjust for that. It's just very hard to get temperature up that far away from the center of the brain.
Yes. Okay.
So I don't like that. And even though the trial met its endpoints, I mean, having done about 180 or 220 pallidotomies with radiofrequency, that was one of the best operations I've ever done. Yeah. Right. Okay. And long lasting and durable. And whereas the focused ultrasound pallidotomy, it's because you can't get low enough to the outflow tract.
Got it.
So what we'll switch to is the pallidothalamic tract, which is the study that just came out, which is the outflow, but in a different target closer to the
Did you do some of these or
not yet?
Not yet. Okay,
we shall.
Okay. Yeah,
we will.
Okay, great. I had Kullervo Hininen on the podcast before, and he, especially in the end of the conversation, also talked about the version 2.0 they're developing of like personalized arrays, and he even in the very end said something like, in the future, 10 years or 20 years from now, everybody will have a fuzz device at home and do things with it, and it might be scary. And I asked him, "Are you joking?" He said, "I'm not joking." So, do you see? What are the next steps in this? I know there's a lot happening with blood-brain barrier opening and everything. What are you most excited about, or maybe new indications of fuzz that might come?
So, I think what we're now. This is neuromodulation, right?
Yeah.
TMS, right? TDCS, these are all, we're stimulating the brain rather than trying to interact with the brain to either enhance function, well, not enhance function, but restore function.
Yeah.
Again, I don't have these grand schema or grand ideas. I tend to be more practical. I try and do the thing that's like clearly ahead of me. But for me, the next dimension in the next 5 years is going to be low intensity focused ultrasound. Because you can explore, you clearly are modulating. We don't understand how it's modulating and whether it's what the mechanism of action is at a cellular level. Yeah. But it's clearly doing something, and you don't create any lesion.
Yes,
at least that we can see on really high quality MRI scans. But you can do low intensity focused ultrasound in a specific target, and you do it for a few minutes, and you have this long sustained effect.
Yeah.
So how do you explain that? Right.
Yeah.
Like something's going on, right? And I think. Even with focused ultrasound, we're still creating an irreversible lesion in the brain. If you could, and there are side effects, with focused ultrasound, there are no standard surgical side effects. No risk of bleeding, no risk of infection, no risk of anesthesia. They're all neurologic. And I can tell you that having done so many, there are subtle neurologic things that you could say, oh, they got great tremor control. Yeah, but what else? Little dysmetria, those kinds of things. If you could do intermittent non-lesional neuromodulation, and that even you could test it on tremor. Yeah. But think of all the other targets in the brain that you'd like to do some intermittent stimulation without instrumenting the brain, without leaving something permanently in there. Yeah. I mean, the world, that's going to be the world. Kullervo's thing is going to be a specific helmet that you'll use and with multiple transducers. And you can target in lots of different places. Yeah. And, if you're feeling a little logy in the evening and you want to write that next paper, you stimulate the reticular activating system and you get...
Yeah, I guess that was the vision to some degree, right? And he said it's scary.
It is a bit scary and futuristic. Yeah. But no, I think low-intensity focused ultrasound will allow us to, knowing what we know about circuitry in the brain and the circuits of different disorders in the brain, as we're way ahead of where we were 10 years ago or 20 years ago. So could you explore it with low-intensity focused ultrasound and see how you modulate that circuit?
Yeah. You briefly, maybe just as a quick question, you briefly talked about advanced imaging sequences, and I know the white meta-null sequences is from Manoj Sharnathan, who also even installed it himself on the 7 Tesla for us. We rarely use it for surgery, but he's been very helpful there. What are these? Were these kind of things game changers for thalamic simulation or fuzz that you can see the nuclei to some
degree? I mean, the first thing was F-Gator for pallidum. Yeah. And you do these high resolutions. I mean, when I did most of my pallidotomies, it was a T1 weighted scan. Sure. You can't see the pallidum, right? You can't, and then it just makes it so much easier and clearer. It wasn't all just sort of voodoo.
Yeah.
Right. So these higher resolution images, specific sequences for the target you're looking at has changed everything.
Yeah.
So it's no longer, approximate atlas coordinates, because everybody's brain's a little bit different. And if you're off by more than a millimeter in functional stereotaxy, you're not going to get the effect you want, or you'll have a side effect.
Yeah.
So it has to be very precise. So these new sequences have changed my life, where, for both DBS, radio frequency, and focused over all three of those things.
Yeah.
Now you're doing direct personal targeting, direct anatomical targeting.
Yeah.
And you'd be surprised how variable it is.
Yeah.
Even in the thalamus, which is,
I'm sure. Yeah.
You
mean the nuclei within even, or
well, no, like from standard stereotactic coordinates for what we think of an adult standard for the thalamus.
Yeah.
70% of the time it's pretty much bang on, but the other 30% of the time it can be off by up to 4 or 5 millimeters.
Yeah.
Even worse for GPI.
Makes sense.
Much worse. The range for the lateral is about 19 to 27 sometimes, depending on the person. So this direct imaging has really enhanced our accuracy.
Yeah.
And so we typically use F-Gator for GPI. It works really well. Manoj's sequences of the white matter null really is specific for the thalamus. Yeah. And now, having looked at it long enough, and I can sort of almost superimpose my own atlas on top of it, I can see the VIM target. It's actually, I'm not sure I'm seeing VIM. I'm thinking I'm CRT coming up into VIM.
Yeah, makes sense. You're past president of the ASSFN, the American Society of Stereotactic and Functional Neurosurgery. Can you talk a little bit about the importance of medical societies and what that brought you?
So I like the smaller societies, and the stereotactic ones are always small.
Yeah.
I think the only reason I got the presidency of the ASSFN was because I missed a meeting, and they said Cosgrove isn't here. We'll make him the secretary, but nobody wanted to be the secretary, right? But then so you gradually, if you do what you're supposed to do, you can go up the ladder a bit. This is where you learn from others, right? And I've always learned more from the Europeans than the other Americans, because in the early days, the Europeans, the French, the Germans, the Italians, the Brits, they all did things more adventurous than Americans, right?
I think this might have changed. I feel like
it's changed now.
More invention here now.
I think you're right. I think you're right now. But I'm talking in the late 80s and early 90s. Yeah. There was in Germany and France, a big stereotactic history, right? Less so in England, but to the same degree. And of course, Sweden. And so I learned more from these people. And so my favorite meeting was always the European Society of Stereotactic and Functional Neurosurgery. I hardly ever missed it, because I'd go there and see all these interesting different ways of looking at problems. Right. I said, I never thought about that, and you talk to people. So these more focused meetings with people of like minds with like experience, these are the ones that are very important. Yeah. You learn a lot.
Yeah.
And I think visiting other surgeons in their operating room when they're doing a procedure, even if you think you know how to do it pretty well, is always extremely valuable. Sure. I did that with whenever I was going someplace and I knew of somebody who, I said, can I come and watch you do a procedure? Yeah. You learn a ton.
And even in the 3 years I've been here now, you've had so many guests that I heard about coming, right? So you must have visit us almost every week or
Yeah.
At least once a month in your OR, right? As well.
Yeah, we have a fair number, but I think mostly because of focused ultrasound.
Yeah. Makes sense. Yeah.
We've refined it where we have an efficient system. We have really good outcomes, I think. And
I wanted to ask about the chocolate thing because that's a
scientifically proven.
Yes. Can you?
There's a double-blind randomized trial that's demonstrated that the
procedure for the
chocolate-covered almond, which has the exact shape of the focused ultrasound lesion, it works. It makes sure that the focused ultrasound procedure works effectively.
For the listeners, the ritual is everybody gets one, right?
Yeah.
Everybody in the room has to eat one, or
generally, unless they have an allergy to chocolate or nuts.
And then only then the lesion will get.
Yeah. Yeah. And we've
practiced for all the 600 cases.
Yeah, basically.
Almost.
Yeah. We just don't want if it's working, don't change it, right?
Of course. I love it.
It's sort of honoring the focused ultrasound gods.
Yeah. I mean, these small things they're important, I think, right? For the team spirit and everything. And so I love that.
It's just to have some sense of humor in what we're doing, But it's because we tried it with, M&Ms and it didn't work.
Okay.
Yeah.
That's good.
Or chocolate covered raisins. It doesn't work.
Okay. Good to know.
Doesn't work.
Good to know. Okay. You mentioned you are the director of the neurosurgery residency program here at the Brigham, probably now MGB, or that's all in flux.
Yeah.
But how important is mentorship and training for the next generation for you? Is it something where you also gain yourself from teaching, or is it just great to see people grow?
Yeah. I mean, this is, I much prefer being a program director than a chair.
Yeah. Okay.
I did my chair stuff. I did 10 years of that. That was enough for me.
Yeah.
What I really like is watching. I mean, it's like being given gifted children as a program director, right? You have the best of the best. They're still children. They still misbehave. They still need guidance. They still need, but it's pretty hard to mess up, right?
Yeah.
But so that's what I enjoy, the personal interaction, watching them develop into mature, capable neurosurgeons, and then sort of saying, "Ooh, I wonder how they're going to, how are they going to take this? How are they going to carry this forward?" I think we learn from each other.
Yeah.
My most loved quote from Osler was, "We all remain students." It's just that some of us are a little more advanced than the others, right? Yeah. But I still learn something every day. Yeah. And that's what keeps life and this work interesting. I mean, you can always learn something more. You can always be a little bit better, and you'd be surprised where it comes from, right? Sometimes my residents are teaching me stuff and other faculty are teaching me. Patients tell you things, right? Yeah. There's always an opportunity but to be a keen observer and listen carefully, and with all of for neurosurgeons, you don't just do an operation. You have to see what you've done. You have to follow these people. The way I learned to do thalamotomies and pallidotomies is I do a post-op MRI on each of these people. And the first thing I do, I rush into the hospital. This was before internet stuff, and you get on my computer, look at the films and say, I could have been 2 millimeters deeper on that one. And that's, that's how you learn on every case. Yeah. It's not just like that. You can't just read books. Course. You got to keep score. If you're going to play the game, you got to keep score. Yeah. And every patient is a scorecard for you.
Yeah, it's interesting. Maybe that also motivated you building this fantastic database in the FUS program now, right?
Yeah.
Where if you don't keep the score, you
could say, they're doing great.
Yeah.
Doing great. Yeah. No, that's not doing so great.
Is there any trainee that you look back where that was a fantastic, I don't know, seeing them grow in your life, of people that you've trained or seen?
Oh gosh, I've trained so many have gone on to such great things.
Yeah.
It's
really hard to see.
It's so interesting. So many people will come up to me at meetings and or they'll reflect on certain things that, and I don't recall it at all.
Sure,
you know,
I can imagine. Yeah.
You know, it's sort of like, you know, that. Oh, I remember when I was a medical student and you let me sew up the dura, and we're going. Yeah, I don't know. You know,
sure.
like, or you did this and you did that. And I said, okay, fine. Yeah.
This has been very long already, so maybe just 4 more very quick questions. Yep. Feel free to answer as long or quick as you want. Can you recall a eureka moment or conversely some waste of your time in your career?
There's no wasted time.
Yeah.
You know, I don't think there's any wasted time. I don't think it was wasted time me doing spine surgery, you know, or because you're always doing something good for a patient.
Yeah.
So, and I think I don't, you know.
Eureka moments? Any particular ones? Maybe the one with Legion and we covered, but
yeah. I mean, there was a eureka moment with focused ultrasound.
Yeah. When
I thought, holy cow. I mean, this is what's the great thing about engineers.
Yeah.
If they say they can do something, they can typically do something. And I said, if you can do this.
Yeah.
I mean, I couldn't believe it when I'm sitting there and hitting a button and I'm watching the heat in real time. I'm going, that was a eureka moment. And I'm not touching the person's brain. Right?
Transitionless. Yeah.
So to me, you know, when you think about the evolution of operative neurosurgery, it actually hasn't changed that much. I keep thinking, in my day, you had a patient under anesthesia with a hole in their skull and 2 surgeons with their hands in their head doing this, right?
Yeah.
If you look in most of the time,
Still the same.
It's exactly the same. 2 surgeons, maybe a microscope in there, but their hands are in the head doing this, right?
Yeah.
Now there's a lot more equipment around, blah, 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 but the basic thing is exactly the same.
Yeah.
And if you go to an undeveloped country, it's very simple.
Yeah.
Head's open. You got a hand in there. You got 2 hands doing the work.
Yeah.
I think the gamma knife with stereotactic radiosurgery, where you're actually, you're doing surgery without physically instrumenting their head. And for me, the eureka moment was, holy cow, first of all, that this all works. I can't believe it all works. It's so complicated, but that it can work, and that I press a button, and in real time you see the heat being deposited as you're doing it, and thinking, wow. And then of course the tremor stops on the table, and you say, well, that was pretty easy, right? You know, that's pretty good, and the patients are smart, you know.
Yeah, I'm sure.
That to me, probably my most recent eureka.
Yeah. Another quick guest question by Melissa to what advice would you give young researchers or neurosurgeons entering the field today, like hers?
Always remain a student. Read everything you can. Observe carefully. And always measure your outcomes. And because you can always get better and better. And be open to opportunity.
You've been great at that,
No, I think it just fell into me.
Well, but you embraced it, right? You had to be open for it. You could have said that you're not interested in fuss, for example, or in the Amigo suite. Yeah.
You know, I think I think we don't know where. Part of you always have to know which opportunity, because there are multiple opportunities in front of you. But you can't be fixed in your direction and say, I'm only going to do this. Like, I was only going to be a cerebrovascular surgeon, and they didn't want me to be a cerebrovascular. That opportunity wasn't available. So, shift.
Yeah.
Alter your.
Do you regret that ever?
No, I think it's fantastic.
Sure.
I'm glad I wasn't. Jesus. You know, that's so hard, and it's so, you know, people die all the time.
Exactly. Function is much more rewarding.
It's much more intellectually stimulating, actually. Technically, from I'm a very good, I love that. I love the technical challenge. I love the pressure of that.
Yeah.
But it's intellectually, I mean, stimulating, but it's not nearly as interesting or stimulating as functional neurosurgery.
Yeah.
And functional neurosurgery has gotten even more interesting.
I'm sure.
Over the last 2 decades.
Are there any missed opportunities of our field, that things we should be doing better or more that we're not?
Oh, no. I mean, I think it's amazing what we're doing. I mean, it's just accelerating.
Yeah.
I wish I was younger, I wish I was younger, and I wish I was more computer literate, and more imaging. I think the thing that changed in my life was the imaging, right? Yeah. And then the computational analysis. I mean, I can't do that now, right? It's, that's not my role anymore.
Exactly.
But if I was a younger person, I would learn this stuff because that's how we're evolving. Some of the danger is that neurosurgery is probably the most intimate interaction between two individuals.
Yeah.
I mean, that patient is going to allow me to operate on their brain.
Yeah.
Doesn't get more intimate than that.
You're right? Yeah.
And what I think was being a little lost is that sense of deep trust that has to be there. So for the young person, you have to be really good at what you do.
Yeah.
Right? Because you have to be good enough for that person to have trust in you.
Yes. Yeah.
And living up to that trust. It's remarkable how patients, they come with a problem and you're trying to help them, but there's still people and patients. And I think for all the technology, we have to sort of say, what would be the best thing for this patient?
Yeah.
Not what I think is best, what I can do.
No, sure.
Right?
Yeah.
Maybe this person shouldn't have a surgery.
Yeah.
Because this and that and the other thing.
Yeah.
So
what if you, like you say, you have to be very good at what you're doing as a surgeon, and that's true, but what if you're not? Or like, let's say, how much is maybe talent as well, do you think, and how much is training? And
well, a lot of it is training. You have to have the basics talent.
Yeah.
Talent is different from skill. Okay. Talent means it's inherent in you. That's a talent, right? Yeah. I have no singing talent. No matter how much I trained, I could not sing properly. Okay. But skill is learned. But you have to have basic talent. And with work, training, discipline, other things, that's how you develop. You can layer skills on talent. Yeah. And that's when you get to greatness.
Yeah.
Okay. If you don't have those skills, you probably shouldn't be doing this.
Yeah.
You should actually figure out what your talent, or if you don't have the talent, you probably shouldn't be doing this. Or if your talent is below, you should do simpler stuff.
Yeah. Makes sense. Is there a particular topic that you feel strongly about that I should have covered but did not? I know I covered a lot, but
this is a lot of rambling around the field of functional neurosurgery. It's amazing when you think about it, right?
Yeah.
What the things we've covered. We didn't really cover epilepsy in much as because that's a whole area.
I'm sure
I've done probably 1,600 epilepsy operations in my life, resections and various things. That's a whole, another field that, I think of as functional neurosurgery.
Of course. Yeah.
It truly is. But,
do you do any DBS for epilepsy as well?
Yeah, we do DBS for epilepsy.
And RNS, of course, as well.
Yeah. That's changed dramatically.
Yeah.
My concern is that the best surgical outcomes in epilepsy are resective surgery.
Sure.
But now everybody wants to not resect anything, But I can tell you, Rasmussen and Olivier and Findel and, the best surgical outcomes I've ever had have been good resections.
Yeah.
And you cure somebody.
Yeah.
You cure people.
Yeah.
But there are a whole bunch of the cases that resection isn't possible and that's where the alternative therapies, but, I hope we don't, forget the historical past of where some great surgical cures have, are possible.
Yeah.
Because we're so enamored with our fancy technology.
Yeah.
You have to be careful of that.
It's even potentially a danger with fast being so easy, quote unquote. I know it's not easy, but that people, maybe even radiologists could get into it, and maybe they could even do a great job if they, study and learn it.
Don't get me started.
Yeah.
Don't get me started. Because the problem is that it's still surgery, right? In order to yes, you could, a radiologist is probably pretty good at targeting if he understood it and developed it. Does he really understand the patient population? Does he understand the alternatives? Can he actually offer an alternative like DBS or medications, various things? Probably not. So then if you have a hammer, everything looks like a nail.
Yeah, that's a good point. It's something you said quite often. I think that since you can offer both DBS and FUS, you're not biased, right?
Yeah, I have no bias. I mean, I can do both and radiofrequency thalamotomy if the skulls are too thick, right? Yeah. So I really have no bias in this. I'm not a one shot.
So Rees, thank you so much. This was way too long for
it's
busy
fantastic.
schedule.
Nobody wants to listen to anything this long.
They will. I'm sure.
No, they won't.
Thank you very much for
my pleasure.